afternoon, everyone. I am Dr. Gutierrez Ramirez. I am a first-year internal medicine resident, and today I will be addressing the myth, is tuberculosis only transmitted by coughing? So, for nearly a century, cough has been implicated in the production of infectious aerosols, contributing to the transmission of Mycobacterium tuberculosis. This belief plays a crucial role in shaping many of our infection control practices and public health strategies when managing TB. But is coughing truly the only or even the primary mode of TB transmission? Are there any other mechanisms that we need to be aware of? So in today's presentation, we'll explore the evidence surrounding this long-held belief. Now that we have introduced the topic, let's outline the objectives for today. We are going to be reviewing the historical association between coughing and the transmission of tuberculosis, present key studies and research supporting cough-related TB transmission, analyze evidence suggesting alternative TB transmission mechanisms, and we are going to conclude whether the myth that coughing is necessary for TB transmission is confirmed, possibly true, or busted based on the evidence review. With that roadmap established, let's turn our attention on the historical context surrounding this belief. And I'm going to be starting talking about Hermann Tapeiner, 1878. Tapeiner was among the first to provide experimental evidence of aerogenous TB transmission. In 1878, his work involved inhalation of experiments where dogs were exposed to dry, pulverized sputum from a patient with pulmonary TB. Postmortem examination confirmed that the dogs had contracted TB, illustrating that airborne particles can carry the infection. Next, we have Robert Koch, 1882. As we know, Robert Koch is recognized for his discovery of Mycobacterium tuberculosis as the causation of TB. In his 1882 paper, read before the Berlin Physiological Society, Koch stated that tubercle bacilli are usually inspired with air attached to dust particles. In an 1884 publication, he suggested that uninfected individuals could catch tuberculosis from inhaled bacilli in the sputum of coughing patients. And then we have Pierre Marie, 1914. Pierre was a French veterinarian who undertook a series of experiments focused on TB transmission involving guinea pigs. Here, I was able to find this article, Droplets, Dust, and Guinea Pigs, an historical review of tuberculosis transmission research from 1878 to 1940. Here on the right side, we can see that in this experiment, Pierre had a patient with pulmonary TB cough into a 10-liter box containing 7 to 12 guinea pigs. During 18 individual experiments, the 7 to 12 guinea pigs were exposed on each occasion to between 30 to 250 coughing episodes for 1 to 2 hours. Infection was successfully transmitted to 31 of the 152 guinea pigs exposed, and these experiments confirm that coughing does play a significant role in TB transmission. We can see that subsequent studies of guinea pigs exposed to human tuberculosis suggest that inhalation of a single bacilli is a sufficient infecting dose. With that historical context in mind, I would like to address the difference between droplet and aerosol droplet nuclei. As we can see, droplets are particles greater than 5 micrometers in diameter. Due to their size, they tend to settle quickly, usually within a short distance from 3 to 6 feet from the source. Infections are transmitted by coughing, sneezing, talking, and close contact of an infected patient's breathing. And surgical masks should be always used prior interacting with an infected patient. Surgical masks, an example of these are going to be influenza virus, adenovirus, and rhinovirus. On the other hand, we have aerosols, also known as droplet nuclei. Aerosols are smaller particles, generally less than 5 micrometers in diameter. They can remain suspended in the air for extended periods of time. the CDC requires additional use of an approved N95 mask. Also, negative pressure rooms to reduce the risk of transmission is going to be needed. Example of this is going to be varicella virus, Mycobacterium tuberculosis, and SARS-CoV. Now that we have clarified that difference, let's see how TB is transmitted. So as we know, TB is an airborne disease caused by the bacterium, Mycobacterium tuberculosis, also called tubercle bacilli. Mycobacterium tuberculosis is carried in aerosol particles of 0.65 to 4.7 micrometer in diameter. Infectious droplet nuclei are generated with a person who have the pulmonary TB disease, cough, shout, or sing. And transmission is going to occur when a person inhales the droplet nuclei containing Mycobacterium tuberculosis, and the droplet nuclei transfer the mouth or nasal passages, upper respiratory tract, the bronchi, and then it's going to reach the alveoli. So it is important to highlight that the probability of transmission is going to depend on several key factors. First one, susceptibility, is going to be related with the immune status of the exposed individual. The infectiousness of the person with TB, which is directly related to the number of the tubercle bacilli that expels into the air. The presence of cough, mostly when this is lasting more than 3 weeks. And if the patient has a cavitary lesion on the chest X-ray, positive culture of positive acid-fast bacilli. Also, it's going to depend on the environment, the concentration of infectious droplet nuclei, the space, ventilation, and air pressure, and the exposure, the duration and frequency of the exposure to the infectious person. As we transition into the evidence for TB transmission without coughing, let's take a look at this article. Is cough really necessary for TB transmission? And the main focus of this article is to review the evidence for site of aerosol production during cough and respiratory activities in conjunction with the characteristics of detectable Mycobacterium aerosols and location of tuberculosis infection. As we know, multiple respiratory activities are produced in health and disease patients in distinct locations of respiratory tract. So in this article, they describe 3 different aerosol generation: bronchial, and laryngeal. And what is important in this article is they mentioned that the bronchial aerosol production is going to be really important. And we are going to see that in this imaging, they are proposing this mechanism that is called bronchial fluid film burst. As we can see in the first picture, this mechanism occurs following a small airway fluid closure in terminal bronchioles during expiration. In early inspiration, the expanding bronchiole stretches the fluid blockage, creating a film which bursts to form the aerosol. This aerosol is going to be drawn into the alveoli in late inspiration prior to the next expiration. So it is important to keep in mind that aerosol derived from respiratory lining fluid is going to be common to all breathing activities, as we can see in table number 1. Tidal breath is going to be able to produce these aerosols with this mechanism, as well as cough, sneezing, speech. And the only important thing is that probably tidal breathing is going to be producing those aerosols in less quantity than cough, of course. So what they concluded in this article is that aerosol production for bronchial and bronchial sources is going to be significant in TB transmission. Bronchial fluid film burst during breathing contributes to generating Mycobacterium tuberculosis aerosols. And bronchial aerosol is going to be common to all breathing activity, but is become more prominent when the deep expiration is going to exceed the airway closure point. And that is going to be achieved when we are coughing, talking, singing, or even during tidal breathing. Next, I would like to present this article, Cough-Independent Production of Viable Mycobacterium Tuberculosis in Bioaerosol. And the objective of this study was to compare direct and indirect sampling methods for detecting Mycobacterium tuberculosis in 38 patients with pulmonary TB. And here's what the study found. They did direct sampling. That means that this was conducted using an elliptical cone collecting apparatus designed to immediately capture the bioaerosol expelled. during different respiratory activities. And we can see here that they were able to detect viable Mycobacterium tuberculosis in 97.4%, with a median bacillary count of 24.5. Indirect sampling, on the other hand, was involved the patient sitting within a chamber for 60 minutes. During this time, patient was breathing normally. And they found, they detect viable Mycobacterium tuberculosis in 90.1%. However, the median bacillary count was 7.5. But it was statistically significant. And I think that this is an evidence that even though in passive respiratory maneuvers, we can still have viable Mycobacterium tuberculosis. Moving on, in this next article, I would like to introduce another finding, and this is a study further show an understanding of how TB might be transmitted via coughing. The objective of this study was to compare the aerolization of Mycobacterium tuberculosis bacilli and total particle matter from 38 patients with pulmonary TB during 3 different maneuvers: tidal breathing, forced vital capacity, and coughing. And as we can see here, they were able to find that across all the maneuvers, the majority of aerolized particles were similar in size. The total particles were 4.4 greater in cough samples than either tidal breathing or forced vital capacity. However, as we can see in the line, orange line, the rate of Mycobacterium tuberculosis production was similar in the 3 maneuvers. So there was no correlation between particle production and the Mycobacterium load, and the variability in production of aerolized Mycobacterium tuberculosis varied much more by individual than type of respiratory maneuver. Next, one of the most notable findings is when data was modeled based on the frequency of breathing and coughing over 24-hour period. And they show that tidal breathing may contribute more than 90% of daily aerolized Mycobacterium tuberculosis among symptomatic patients. That means that coughing. That is because we are going to spend more time breathing than coughing in a day in TB. And this last study analyzed tuberculosis prevalence surveys across 8 countries. They reported prevalence of pulmonary TB based on chest X-ray and screening of symptoms, and TB was defined by positive cultures. And it is important to highlight that they did 3 differentiation for subclinical TB with no persistent cough, no cough at all, and no symptoms at all. So we can see here that total TB cases were 1,944, and after adjustment, no persistent cough, that means that they took in count patients with a false negative chest X-ray. After they did the adjustment, it shows that no persistent cough represent a proportion of 82.8%, no cough at all, 62.5%. And no symptomatic patients, they were able to identify the 27.7%. Also, on analysis of the smear examination results, they found that 29.1% of patients with no persistent cough tested positive on the smear, and even the 23.1% of patients who tested positive on the smear have no cough. So we can see that without coughing, people can still have a positive smear result, meaning that they can potentially spread TB. So as we conclude the scientific discussion, it's important to highlight that another factor that we overlook is sometimes implicit bias. I will say that in 2022, an estimated of 10.5 million people fell ill with tuberculosis worldwide. TB is going to be present in all countries and age groups, and it is important to recommend screening and treatment options for all eligible patients. On my conclusion, I can say that while classic TB symptoms like coughing are strongly linked with higher rates of infectiousness evidence suggests that coughing is not the sole mechanism for transmission. Infectious particles can be aerosolized through talking, singing, and even with a normal tidal breathing. However, more research is needed to refine and validate diagnostic methods that detect transmission without obvious symptoms. Subclinical TB can also potentially drive a substantial fraction of transmission on a population level, and emphasizing the need for ongoing investigation and improved public health strategies. Thank you so much.
Does anybody have any questions or comments? Dr. Jose?
Great job. I was skeptical that she was going to be able to find enough evidence to give any support to this, and I'm absolutely convinced.
Yeah, it's. I'll just make one comment. It's surprising that, well, we've all been taught this, and nobody's really, and there's been a lot of data to show that it can be at least put out into the air with just normal breathing, similar to COVID. We went through that whole thing. Is it a droplets or aerosol or whatever, and what kind of mask do you need, and everything. We went through the whole thing. But I mean, it's been what, 140 years or something that they've been working on TB. No one has actually done a study where they've actually demonstrated transmission from person to person or person to animal without cough. I mean, nobody's even done it. She looked really hard. The librarians looked, and it's amazing to me. No one's actually looked at that. But there's certainly enough evidence that it is put out into the air and certainly can be breathed in without it. Anybody have any other comments? Thad? Dr. Bordowski? Or can't see who that is in the back.
It's Aaron.
Hi, Aaron.
I thought.
You're wearing a mask.
Yeah. But I don't have TB, so
Okay.
don't worry about that. I was just curious. There were some good studies about, production. A large percentage of production happening through normal tidal breathing, but were you able to find any simulation studies as to maybe increased radius of spread with coughing, or different actual particle dynamics of if the transmission would be more frequent because of the projectile physics of it versus tidal breathing?
No, I wasn't able to find that, but what I saw is that, of course, cough is going to produce more mycobacterium particles than tidal breath. That's why tidal breath is going to contribute, but we need to be exposed to that breathing for longer times than just coughing.
After that Seinfeld episode with the dog and the Kramer, whatever his name is, having the cough and then seeing the guinea pigs being infected, are there case reports of tuberculosis from spread through animals that you came across? I know you asked if there were other ways, and it kind of came up in both parts of the presentation, so I was just curious.
Yes, the one that I read was with Pierre Mariches, and he did two experiments. The first that they did, he was with an 81 literal box with the guinea pigs, and they came back without infection. Then he switched the experiment to 10 liter box, and that's when he found that the guinea pigs became infected. And that was back on 1914 when they started to do that.
I'm not sure there have been any other real good studies, and and as far as the distances, I think the concept is that the aerosols put into the air, and these aerosols just hang out in the air. They don't drop like droplets to the floor. So there shouldn't really, obviously there's going to be some distance, but you could probably be quite a ways away from it if you're in a closed room and still it's still suspended in the air. So just like COVID, I think we found that. Certainly the closer you are to the source, the higher the risk, but that doesn't mean you can't get it otherwise, right?
Yes, it harkens back to the miasma theory of disease.
All right. Is it a myth pulmonary TB is only transmitted by coughing? So how many people think that this is true? It's not a myth. 1. How many think that it's plausible that it could be transmitted other ways? And how many are pretty convinced that this is just a myth that could be transmitted, maybe not as frequently, but as cough, but so it looks like the majority. Yeah? Okay. All right, we're busted.